Thank you very much. We've heard some great programs today, great panels, great individuals talking about physician wellness, but not only physician wellness, the wellness of all personnel in our healthcare system, because an event of one individual affects everybody. And therefore, we all have to be a part of prevention, a part of understanding. So in this session, we have an objective, and that objective is as follows. An experienced leader reflects on their journey in healthcare by highlighting the impact of the learning environment on clinician well-being, describing aspects of leadership and training that foster success and well-being in the practice environment, and exploring how internal partnerships can positively affect the learning and working environment. So welcome to our discussions on leadership narrative and how we can all play a role. We have heard and read about physician burnout, how burnout can negatively affect quality of patient care, result in physicians leaving, and therefore shortages in the practice of medicine, especially in certain communities. And thus, this really contributes to workforce shortages and deficits in various areas. We recognize that there is a base of research and literature that addresses and identifies potential interventions and strategies to either prevent or alleviate burnout. Dr. Ron Paulus with me has had significant experience as an advisor to Hospital Corporation of America. He has been a member of other leadership teams and membership in the C-suite. So Dr. Paulus is going to tell us some things about how the C-suite and leadership can play a role in preventing and remediating physician burnout. So the first question that he will address is, how can members of the C-suite play a role in prevention and remediation? He will also discuss some about the financial aspects of preventing and remediating burnout, because as organizations undergo change and there are individuals leaving the institution as a result of burnout, this really reflects on the ultimate outcome and bottom line for the institution. So secondly, Dr. Paulus will discuss how leaders can really impact on overall institutional burnout, and thus reflect on the overall institutional outcomes and bottom lines. So, Ron, if you want to go on and start with your discussions, and then we will have time for additional questions and questions from the audience on leadership.
Great. Well, thanks for having me. It's a privilege to be part of this event today. I didn't realize it, but I was getting feedback on what leaders do and don't do, mostly don't do, in my prior panel discussions. My leaders don't care about this, my leaders don't care about that, and so forth and so on. But you know, as a kid, my mother said something to me more than any other phrase across my lifetime, and it was, your job is not to accept the world the way it is, but it's to make the world the way it's supposed to be. And so I really do think that leaders are required to grab this issue by the neck and do something with it. I really believe that human-centered leadership is the essence of what we're talking about here. I have my own personal experiences, both as I did the lifetime tuition plan at the University of Pennsylvania. I know there's some other Penn people here, undergraduate medical school, business school. I won't talk about all of the traumas experienced there, and not to mention Medicine 200 specifically, but a very less than embracing time at times, and other times I had some of the greatest mentors I've ever met in my life there. So it's about heterogeneity and diversity. And I would raise the question of, I don't think healthcare leaders yet, I think they're coming around, have a deep understanding about how caregiver burnout impacts individual team and business performance. I don't think they realize we don't have the right measures. And I don't think they understand that there's a pretty comprehensive blueprint solution opportunity that sits right in front of us. The first thing is, from a measurement standpoint, we talk about burnout over and over again, but burnout is not the opposite of thriving, right? We need a different set of metrics, a different set of measurements. And so a number of years ago, two colleagues, Bill Maples and Bridget Duffy, and I formed something called the National Task Force for Humanity and Medicine. And in 2015, we had 50 people at the Wing Spread Retreat in Wisconsin, as a coalition of the willing. And we began to work on this. And included in that group were Marcus Buckingham, who had been the lead Gallup researcher on employee engagement globally, and Brian Sexton from Duke, who's done a lot of work on measurement. And so one of the things is about measuring thriving. So questions like, I have a chance to use my strengths every day at work. I feel like I'm making a meaningful difference in my role. These are not burnout type questions. Emotional recovery. I always bounce back quickly after difficulties. I can always regain a positive outlook despite what happens. And so many other questions, 4 in each category. But until we get there and start measuring thriving, we're never going to get our arms around this problem. Now, we've approached this with sort of what we call the 4-legged stool. The first is, and this doesn't get much of any attention, is you have to create a safe work environment. And when I say safe, I also mean free from violence, free from verbal abuse, free from all of those things that we as caregivers take. It's a national crisis. This one's now being talked about. The violence against healthcare workers is not. 75% of all OSHA issues occur in the healthcare and social services setting. But it also includes supporting people who are exposed to trauma as part of their daily work. So things like Code Lavenders, where you send a team to embrace someone with emotional support after a traumatic event. We had an example where a mother, unfortunately, took a hatchet to her 3 children, and they were all brought into the emergency room. We have a structure set up to then wrap them with support after that. How can any normal person respond to that, right? Leg 2 of the stool is to eliminate hassles and barriers. Too often we focus on blaming the individual. If you were stronger, if you were more resilient, if you were more whatever, you would do better. But we have a duty as leaders to eliminate not just the moral indignities, as was mentioned this morning, but every little tiny hassle and barrier that gets in your way. The computer that won't boot up, the voice recognition that doesn't recognize your voice, all of those things. But to also scale joys, right? So it's not just about eliminating barriers and hassles, it's about identifying and scaling joys. What's scaling a joy? Well, when the hurricanes hit Puerto Rico and all the small IV piggyback bags went out of existence, we have teams that go around and we call them Mission Renew, and they just observe for hassles and barriers, but they also observe for joys. And they saw that when we had nurses doing slow IV pushes, that they had an incredible bond with that patient and family. Sometimes it was tears, sometimes it was laughter, but boy, was it intense. And so we made a decision after seeing that that was such a bonding time. We don't use IV piggybacks anymore. We do slow IV pushes to hardwire into the day a joyful experience in a way that will be beneficial to both the patient and the caregiver. You have to have a team environment that's connected to a purpose that's greater than yourself. So we talk about our mission, and we talk about how each person is contributing, and the role of a leader is to connect the work to the purpose. That makes the individual feel good, and it makes the team environment work a lot better. Lastly, personal well-being and resilience. And I was a skeptic on this one, right? I'm a data-driven guy, and I was like, okay, what's next? Pyramids and copper bracelets, whatever. But I actually looked into the science, right? Because I'm still a learner, and the science around meditation, gratefulness, movement. It's as strong as most of what we do in all of medicine. So the last leg of the stool is around personal well-being and resilience. And we used a program called Life XT, which was out of a book called Start Here, written by Nate Klemp and Eric Langsher. So what happened in closing here, over a couple of year period, we went from below the national average of percent of employees fully engaged. Anybody want to know what the average is? It's not good. 18.6%. So we were like 17 something, but we went up to almost 40%, more than double the national average. At the same time, we reduced mortality by more than 40%. We improved our patient satisfaction to above the 90th percentile. We significantly reduced turnover. We were named IBM Watson Top 15 Health System in 6 out of 7 years. We performed at the 98th percentile of the nation in the last measurement period. And our skeptical physicians and other clinicians that went through the Life XT program had a 98% satisfaction rate, and 99% said they incorporated something into their daily lives that they felt helped them not just at work, but at home. Lastly, I'll recommend one book to you that was assigned to me by my aggressive HR leader and my chief of staff, who's a wonderful colleague. It's by Ben Zander, who's an orchestra conductor, and it's called The Art of Possibility. In that, he really tries to share that it's the frame of reference that we bring to things that determines how we view the world. And he argues that instead of focusing on how you measure up, you focus on how you contribute to the world around you. Contribution is not measured based upon other people, it's based upon you. And everything in life is based upon our own frame of reference, and often by turning things around, you can see things in a very different way. His last thing, which all of my executive team used regularly with me, was called Rule Number 6. Anybody read the book in here? You know what Rule Number 6 is? Don't take yourself so damn seriously, right? That's and anybody can call Rule Number 6 on anybody on our team anytime they want. So in closing, none of this is going to change unless leaders embrace this. There is a business case for it, which I'm happy to talk about. But really, I think human-centered leadership and creating an environment when everybody can be the best that they can be is what we owe ourselves, and it's what we owe our patients.
So, Ron, thank you so much for those comments. You and I have discussed similarities in your leadership strategies and that of the military. And of course, I've had a long history in the military. And I understand that military leadership, of course, is referred to as the influence of or missions, and how you're going to accomplish these missions by providing the purpose, the direction, and the motivation. And therefore, commanders, depending on their area, have to work with their subordinate to accomplish the mission. And one of the teachings of General Colin Powell, when he said, leadership is really solving problems. The day soldiers stop bringing their problems is the day you have stopped leading them. So my question to you now, as a leader and a leader in healthcare, how does the leader, the CEO, obtain all the information from the department chairs, from the residents, from the staff, from the medical students, all of these individuals, in order to reach the bottom line for the healthcare system or for the institution? How do you do that?
Well, it's through other people, right? You're not some rugged individualist hero as a CEO that goes out and solve all the problems yourself. You have to enable and support people so that they can do that. A quick anecdote from my first couple of weeks as CEO at Mission Health in Asheville, where I've been until very recently. And we started doing a thing called, probably many people do now also, or maybe you did it before us, quality safety rounds. So I was there. All of the unit staff were there, including the housekeeping staff. Everybody that impacted that unit was on that floor. And I asked people at the end, does anything get in your way? And first of all, they were not used to a CEO being out, interacting clinically. Okay, that was weird for them. Everybody's staring down at the ground until one nurse sort of lifted only one eye. Only one eye went above the midline. The other stayed flat. And she said, well, I could use a thermometer. And then someone else says, well, I could use a blood pressure cuff. Now, behind the scenes, my blood pressure's rising, right? I'm like, how in God's name could they not have long story short, I took the senior team in and I said, if this randomly happened here, I said, I want to do a systematic sweep of all units. I kid you not, $12.3 million of minor equipment later, everybody had the stuff that they actually needed on the floors. Now, the point of that is that there's no way for the CEO to get all of that input. But there has to be an environment, just like was described in the prior dialogue about a safe, open, ability to fail, ask questions, learn. Once the environment is created, then you'll get all the information that you need, and it doesn't come through traditional, employee surveys.
Okay. And now an area I know you sometimes don't want to talk about, but you expound on, and that is the area of the electronic medical record. Of course, the EMR has been identified as a major contributing factor to burnout for physicians, but not only physicians, but other medical personnel also. Can you describe your measures and your strategies for maximizing utilization of the electronic medical record, but yet allowing the EMR to be a process that medical professionals really embrace? What was your strategy?
So let me start with this comment so I don't get stoned in the room. The EMR is definitely a hassle, okay? And it's less than ideal. It's imperfect like most things in life, and I understand why people are frustrated by it. That said, it's a crutch for people to say that the EMR is what causes the burnout, right? Because the EMR doesn't take your connection away from your purpose. It doesn't change, it doesn't have to change the way that you have humanity in medicine, but it goes back to the system level leg of the stool. If you don't acknowledge that the EMR is a burden and you don't do your best to try to mitigate that and minimize it, then A, you're not showing you're caring, B, you're showing you're not listening, and C, you're just allowing more hassles and barriers to go in the way. So that Mission Renewed team that I described is a group of people that we have that just goes from unit to unit to unit. It always includes a nurse clinician performance improvement person. It always includes an IT professional, and they observe what's happening in the work environment. Because when you do focus groups, I've been doing this for 20 years plus in IT. And when you do focus groups and surveys and all that, you'll never actually find out what's going on because people can't articulate what it was in the moment they remember the last thing that they did. You've got to go watch them side by side. And so they look, and sometimes it's a printer doesn't work, and this doesn't log on, and this computer needs to be replaced. This voice recognition needs to be tuned, whatever it is. But I think now within Mission Renew, they keep tallying it up. I don't remember. The last I saw was 6,186 hassles in the EMR that we'd eliminated. We also do stuff like we measure when people are charting when they're not at work. It's easy to do. You know that if they're charting when they're not at work, unless it's an unusual circumstance, there's a problem. There's a problem in training. There's a problem in work environment. So you have to come at it. But what you can't do, and don't hate me for this, you can't allow that to be, it's just the EMR. It's not just the EMR. It's much deeper than that.
Okay, thank you. So Dr. Paulus has tremendous experience in leadership in the C-suite. He has been able to get out into the trenches, as I call it, and
the fun places.
Work with people. So I'd like to now open the program for questions from the audience. Are there individuals who would like to ask ask questions? Yes.
It's that on-off button.
I pushed a button there. I'm Carol Bernstein from New York. Thank you so much. I do believe that enlightened leaders are critical to the future. What suggestions do you have to help us with the unenlightened ones? Sorry.
You can take that.
Yeah. Send them to meetings like this. No, I think, it's like human behavior in general, right? Hopefully they're unenlightened because they're literally unenlightened as opposed to being obstinate and unwilling to become enlightened. If they're in the latter category, they just need to go. I don't think there's any time left for those people. If they're in the former, it's what you do in social circumstances. You work through other people who they will listen to, and you frame it in a context that they can relate to. So for some people, it's ROI. People always want to know about ROI. ROI is dramatic in this space. If you just look at 2 items alone, turnover, our task force has estimated that nurse turnover cost about $9 billion incrementally due to burnout. Now, why? Because it costs about 1.2 to 1.3 times the nurse's salary to replace him or her. You've got traveler expense in the interim. The average turnover rate is about 16, 17%. And when you have high burnout, it gets into the 20s, right? So you calculate the delta. With physicians, it's a lower turnover rate, but a health system's still about 21%. You lose about $1 million in lost revenue from a physician not being there for a period of time. It cost about $100K to recruit one and $200,000 of startup. Right there, across just hospitals and health systems, you've got almost $15 billion worth of cost. Now, you tell me anything else. If length of stay was costing that much, there'd damn well be people all over that. So it's just about framing the problem.
Thank you. We'll go to microphone number 2.
Sammy, thanks for your comments. Question, can you compare and contrast the approaches that you've seen taken from the executive for workforce development or talent development from the sort of the human relations side as compared to the clinical learning environment side and the, like medical staff, et cetera?
Okay. So it's a very interesting question because at least at Mission, and, I don't know, I just try stuff, right? Because, accepting the status quo is just not a good thing. So we gave a lot of consideration to how we should or shouldn't incorporate medical students, residents, physicians, whether they should be alone or separate versus nurses, pharmacists, executive administrative leaders, et cetera, et cetera. And we ultimately ended up going with a hybrid model. We started out the and we still do. We still start the training with like group. We felt that it was too big a leap to expect people who hadn't gone through multidisciplinary training together to, sort of share their deepest, darkest secrets and become vulnerable in front of a wide group of people that would otherwise be supposedly subordinate or superior, as the case may be, to them. Once we get past that, then we reintegrate them back together. And we've now iterated to, for example, in our Leadership Development Academy, we now do leadership development with the entire team, right? So it's the docs, the nurses, all of that in conjunction. Historically, which may have been more apropos to the core of your question, they've been running 2 parallel universes, right? I was trained on a see one, do one, teach one, and then publish one, model. And in the human resources organizational dynamic environment, it's much more group-based and much less fully experiential and a mix of didactic and experiential in a supportive environment. So that's I don't know that I have the right answer to your question, but that's sort of how I've looked at that.
How about number 3?
Okay, 2 questions. That was an excellent quick discussion. I love what we're moving through this very quickly. I'm Marie Brown. I'm a practicing internist and work with Dr. Christine Sinsky at the AMA. And when you talk about, so my first is about the EHR. And what we hear is we do blame the EHR for pretty much everything because it's an easy blame. But the EHR and the computer are not the same. And so you have a vendor, but you also have what we see is this overinterpretation out of fear of some of the rules. So we know what we need to do, but it's the compliance officer or risk management or some other organization that's at the C-suite and untouchable, who's not listening or seeing what's going on in the practices, that we can't. How do you get them on board to not overinterpret the rules so that we're not doing meaningless work that keeps us away from having the time to deal with our patients? And second, is aligning the compensation of leadership to workforce wellness the way to engage the C-suite? And I mean, even not just the top three, but the compliance officer and the lawyers and the head of quality. So those two questions, I'd appreciate your comments.
Sure. So many have termed the electronic medical record as being an annoyance. You can't do it. You don't learn about it. So an institution really has to develop an educational program where all who are involved can participate. And electronic medical records are not finite. They can be changed. They can be modified for the institution. And therefore, discussions and educational programs make a difference where you have individuals who can control the components of the EMR, go work with the teams. And what we've done is had these teams go from one area to another to find out how they work, what is important, what is not important, and therefore changes made. Now, whether it could be tied to compensation and others, I think the details of how that could be worked out or should be worked out, and how that needs to be done. My experience in the military, however, the compensation didn't change. It was just that teams got together and worked on those processes.
Yeah, I'll speak to.
So, go ahead.
Yeah, I'll just add to that. So I knew that the EHR was getting too much blame when someone told me it was responsible for the Middle East, but that's just a whole separate issue. But you're right, and I would argue that that's another responsibility of leadership. You have to make trade-offs between compliance, quote, interpretation, and real-world on-the-ground factors. To your point on compensation, we did it, right? So 20% of our compensation, my compensation, all of the senior team's compensation was specifically tied to well-being metrics. And I think just like you have to incent financial performance and patient satisfaction and clinical outcomes, you've got to include this because it's the centerpiece of everything that we do.
Okay, thank you. One more question from microphone number one, Dr. Brady.
Thank you, Donald Brady, Vanderbilt Medical Center. I really appreciate your comments today, Dr. Paulus. And I'm wondering, as we think about our true full healthcare system, as we think about the patients, and there are the for-profit healthcare systems, there are the not-for-profits, there's the academic medical centers, there are the Grady's and Jackson Memorials and inner city New York hospitals that don't have the resources that some of us do. As we think about the well-being of the patients and the hospitals that are closing, where many of our trainees are out in rural environments, how do we bring the C-suite leadership across the varied settings in which we work and practice as caregivers to try to promote this wellness initiative across all the span of the environments that we serve?
Fantastic question. I mean, I've been doing my best since 2015, and the reality is it's getting more attention all the time. So I think, we want to look at the glass half full, and here we are today, right? I do think I feel lonely as a CEO in the audience. I don't. You might get some more. Victor, you're there, but yeah, recovering. Yeah. But I think we've got to get people into these meetings, and I think the AHA is doing some good work at trying to make this a more important and inclusive factor. I think Christine and the AMA are doing their work. I'm less familiar with the nursing infrastructure and so forth, but we just got to keep at it because Rome didn't get built in a day, and neither will this. But if we stay on track, we'll make it.
Thank you. I'd like to thank everyone for participating and staying in the room today. And I would like to finish this session with another quote. You can tell General Colin Powell is a hero in my area and has taught me well. And what he said was, perpetual optimism is a force multiplier. So we've got to continue to do research, to collect data, to make sure that we are developing programs to prevent burnout or to remediate it if it occurs. But of course, promoting wellness so that not only are our institutions flourishing and doing well, but also our personnel in those institutions. We must be diligent in our efforts to research and understand physician wellness and thus to prevent and remediate burnout. Not only is it the right thing to do, but it is the best thing for our people, the best thing for our institutions, and the best things for our patients. So this concludes this area of the program. We have a break now, and when you return from the break, look on your name tags, and the number of your table is on the yellow sticker, and that corresponds to your assignment for the next session. Please return to the room at 3:30. Thank you.